Hi guys, welcome back. This is Dr. Marva and currently we shall be discussing regarding chiary syndrome. This happens to be a disorder which can contribute to acute abdomen as a presentation. Mostly patient will be having a right upper quadrant pain. So let's quickly understand why would you be having a chiary syndrome and what would be the manifestations that would be occurring in the patient. If you look at the representation of the diagram which is given here, you can definitely see the three hepatic veins, the right, left and the middle, and they are the ones which are basically carrying ammonia free blood. I would say like this, that the portal vein of ours would be sending in ammonia into the liver, and one of the basic function of the liver will be that it will detoxify the ammonia by combining it with carbon dioxide, forming urea and excreting it out. Now what happens in chiary syndrome is that there could be a thrombus formation in the hepatic veins, like I am shading thrombosis development in the hepatic vein, and that will definitely contribute to a backward pressure, and therefore in the hepatic sinusoids there would be a significantly increased pressure which could result in development of a centrilobular necrosis. For development of chiary syndrome, the thrombosis usually starts from one of the hepatic veins and then spreads over to the contralateral hepatic vein and then involves the inferior vena cava also. And therefore, if they ask you in a question that what is the etiology behind chiary syndrome, then the vaso-occlusive thrombus that develops in the patient is not primarily in the IVC. The thrombosis occurs in the hepatic veins and then can ultimately involve the inferior vena cava. Logistically speaking, the definition of chiary syndrome is thrombus in greater than 2 or equal to 2 hepatic veins. It is usually not possible to have chiary acute presentation with single hepatic vein obstruction. Usually it is at least 2 hepatic veins that need to be blocked to cause a sufficient end backward pressure, contributing to congestion in the sinusoids and then a centrilobular pressure based necrosis resulting in development of mortality. You also know the fact that the caudate lobe in the liver, you see you have a quadrate lobe and a caudate lobe. The caudate lobe usually drains directly into the IVC, and one of the easy findings on ultrasound in these patients would be that since the caudate lobe drains into the IVC, if you would be having a IVC thrombosis, then the caudate lobe would enlarge. So inferior vena cava obstruction can be identified on a color Doppler and even on an ultrasound initially, since primarily there will be a straightaway enlargement of the caudate lobe of the liver. So one of the early tests which can be done in the casualty, you see you have a guy with a right upper quadrant pain. Obviously you might think cholecystitis, cholelithiasis. You'll do an ultrasound in the casualty and well, the gallbladder is normal. There are no stones, the gallbladder thickness is normal, no inflammation in the wall of the gallbladder, but what you're getting is a caudate lobe enlargement in a patient who's having a right upper quadrant pain. Then your thought process is obviously it's not a calculus cholecystitis. Obviously it's not calculus cholecystitis because the start gallbladder is clean. So it's not a calculus cholecystitis. You have to switch on the Doppler. You have to get a color Doppler done to identify chiary because the mortality rates are high and obviously no gallbladder patient will ever die even if you delay the surgery. The basic concept is chiary syndrome begins with development of thrombus in at least 2 hepatic veins. The increase of sinusoidal pressure and the back pressure will contribute to even hepatomegaly. In this condition, there would be stretching of the capsule of the liver. So that explains the right upper quadrant pain developing in this patient. And obviously the pressure in the portal vein will also increase. So it is described as a post-hepatic cause of portal hypertension. Obviously it depends whether the intrahepatic part of the hepatic vein or the extrahepatic part of the hepatic vein is getting involved, and it is not always the fact that there could only be a thrombus which could be developing in the hepatic veins contributing to chiary. Let me say hypothetically patient is having a tumor. This tumor can increase in size, and this tumor, when it increases in size, it can compress on the hepatic veins of the patient. So sometimes you might read the word secondary chiary syndrome where you might be having a tumor. Or let me put it like this, you are having a giant hydrated cyst, and this giant hydrated cyst, normally hydrated cyst is asymptomatic. Hydrated cyst causes a painless hepatomegaly, but the same type of hydrated cyst or multiple hydrated cyst in the liver is now having a severe right upper quadrant pain. Why? Because the hydrated cyst is increased and it is compressing on the hepatic veins from outside, contributing to increased pressure in the sinusoids, a possible sinusoidal necrosis, and obviously a portal hypertension developing in a patient. So any condition from outside, if it is pressing, whether it's a tumor, whether it's a hydrated cyst, whether it is presence of a Wilms tumor or renal cell carcinoma, then we call it secondary Budd-Chiari syndrome, and the intrinsic cause is obviously a hypercoagulable state. So let's now study why is Budd-Chiari syndrome developing overall, like what in the MCQ should you answer as the most common cause. So if in a question he says what is the overall most common cause for development of Budd-Chiari syndrome in a patient, then your answer is hematological disorders. The hematological disorder that I am talking about would be either polycythemia vera, or it could be paroxysmal nocturnal hemoglobinuria. Well, there are unnecessary controversies regarding whether PNH is more common contributing to Budd-Chiari or polycythemia vera is more common contributing to Budd-Chiari. There is no study which has given a conclusive evidence. So you need to do genetic studies in these patients. You all know the fact that PNH is related to PIGA gene, whereas polycythemia vera is related to JAK2 mutation. So genetic studies also need to be done for evaluation of the cause. Like for PNH, you also need to do a flow cytometry, because CD55 and CD59 are the ones which are affected in PNH. And without going into hematology, I want to say the fact that these are two leading causes for why would you be having Budd-Chiari. In some MCQs, however, if he wants to test your knowledge beyond these, he might give you a scenario of a thrombotic diathesis. He might say that the person has already had recurrent deep vein thrombosis episodes. The conditions that I'm talking about are protein C, protein S, and antithrombin 3 deficiency. You all know the fact that these are anti-clotting systems, and if the anti-clotting systems in the body will become lesser, then the clotting tendency will increase in the body. He might mention regarding the most common hypercoagulable state, factor V laden mutation. Factor V and protein C, they bind with each other and they keep each other's activity in check. In factor V laden mutation, the binding between factor V and protein C is defective. If you have a defective binding and the activity of factor V is unchecked, then unchecked factor V can activate the extrinsic system of clotting and can trigger a clot formation. The point is, guys, that whether he gives you a person who's had a recurrent deep vein thrombosis episodes followed by development of a right upper quadrant pain and a diagnosis of Budd-Chiari, or he gives you a hematological disorder, the point is that ultimately you should be able to tell the investigation choice or the next step for management of these patients whenever he's giving you a scenario like this. Postpartum obviously is a rare one. Then from female perspective, even the old generation OCPs, you see nowadays we are using the word COC, combined oral contraceptive pills, but earlier the word used was OCP. The OCP that was containing estrogen in a dose more than 30 mics. Nowadays all the pills, the government ones or the standard ones, are always having estrogen of 30 mics or lesser than that. But the older ones which were having high estrogen, they contribute to a hypercoagulable state and could contribute to it. Then, like I said, tumors. Tumors could be like metastasis to the liver from colorectal carcinoma. It could be metastasis from breast cancer. It could be a primary liver cancer, hepatocellular carcinoma. It could be renal cell carcinoma. It could be in pediatrics, Wilms tumor. The basic point is, if you are having a tumor pressing on the hepatic vein from outside contracting to Budd-Chiari, we call it a secondary Budd-Chiari syndrome. Even infections. Now, the infections that are routinely responsible for this could be hydrated cyst. Obviously important topic from surgical domain. You need to read that hydrated cyst will always be having a painless hepatomegaly, but it can become painful if there is a Budd-Chiari syndrome developing in the patient. Then could be connective tissue disorders. Connective tissue disorders responsible for this could be like Behçet's disease, sarcoidosis, Eplus. Eplus, for some strange reason, has become a hot favorite of our examiners in past 2-3 years. So antiphospholipid antibody syndrome, APS or APLAS as they call it, antiphospholipid antibody syndrome, which occurs due to this antibody. I hope you remember the name for rheumat, anti-beta 2. glycoprotein antibody. This, what it does is it activates the intrinsic system of clotting, and intrinsic system clotting activated will cause clot formation. Remember, in factor V Leiden mutation, I had said it is the extrinsic system of clotting that is activated. In antiphospholipid antibody syndrome, the antibody causes the intrinsic system of clotting to go into automatic mode, and therefore clot formation will occur. Then could be rarer causes, surgical causes, like presence of a membrane in the IVC or membrane in the portal vein of the patient. So membranous defects of the hepatic vein per se or involving the IVC could contribute to this. Then he could mention hypoplasia of the suprahepatic veins. He could mention malnutrition. Parenteral nutrition has also been documented. The IVC catheter can contribute to development of because any catheter in the body is a foreign material, so the IVC catheter could also contribute to it. So these are the usual causes why Budd-Chiari syndrome would be developing in a patient. MCQ wise, especially wanted to remember hematological and thrombotic diathesis in a patient. The remaining are, I would say, relatively less important, though anything is what he can ask. Now let us look at how the presentation of Budd-Chiari syndrome will occur in an acute situation. It's an acute abdominal emergency. It could be fulminant presentation as well. Obviously, in some cases, you could be having chronic, subacute presentation. But what I'm interested, why I'm discussing this topic, is right upper quadrant pain, and you are thinking cholecystitis and turns out to be Budd-Chiari. So this is what he says in the textbook. For diagnosis of Budd-Chiari syndrome in a patient, you would be having clinical features in the form of a triad. BCS is Budd-Chiari. The triad to be remembered is abdominal pain. Due to sudden stretching of the capsule of the liver, the patient will be describing tenderness and pain or discomfort in the right upper quadrant. This will be associated with development of ascites. The ascites is explained by the fact that there will be a development of sudden onset portal hypertension in the patient, because blood can go in the liver but it cannot go out because the hepatic veins in the IVC have been blocked. The third feature that will tell you that this is a Budd-Chiari syndrome is hepatomegaly. A triad of three things: a sudden onset, acute abdomen, right upper quadrant pain with ascites and hepatomegaly is a diagnostic feature seen in this condition. In the later part of the illness, even jaundice will start coming. Why? Because there will be a necrosis in the liver due to increased backward pressure. The pressure will be maximum in the central part, as I have said, and I'll just go back in the slide. Is if you look at this slide, you can see the fact that the backward pressure will contribute to the necrosis mostly occurring in the centrilobular area. This is the lobule of the liver. So in the centrilobular area, periportal fatty changes, periportal fibrosis can also be present, but mainly the damage will occur in the central part. So that's why I said necrosis will occur, and that would contribute to development of jaundice in a patient. Jaundice is usually not seen in the subacute form or in the chronic forms, but it is seen only in the acute form. So I'm writing plus minus to say that if this is not present, doesn't matter, you may not get jaundice in Budd-Chiari syndrome. In the acute presentation, there will also be a development of hepatorenal syndrome. So renal failure can definitely occur in a patient. Guys, please appreciate the fact that if the IVC will also get blocked, you see I'm saying if the IVC will get blocked, then it can also kill the patient, because the venous return to right side of the heart will reduce, and this will contribute to development of obstructive shock in a patient. The causes of obstructive shock that I've taught you are during the course of this lecture series is: one is cardiac tamponade. The second cause for obstructive shock is tension pneumothorax. The third what I'm mentioning is that if you are having a even complete IVC occlusion, then Budd-Chiari syndrome will also reduce the filling of the heart, and that will contribute to obstructive shock developing in the patient. Due to back pressure changes, there will also be a pitting pedal edema developing in this case. These are the standard presentations that would be encountered in patients who are suffering from Budd-Chiari. You could obviously be having collaterals developing. You could be having superficial veins of the abdomen. You could have caput medusae. There could be collaterals developing in the chronic form of Budd-Chiari. The definitive treatment for Budd-Chiari syndrome is liver transplantation. What I have written plus minus is to highlight the fact that in the acute presentation, these jaundice and renal failure will obviously not be seen. And in the chronic form, it would be the collaterals that could be developing, or portosystemic collaterals that could be developing, could be a presentation in this patient. Now, if he says what is the first test to be done for diagnosis of this condition, it is obviously a ultrasound. And following a ultrasound, what I'm going to do next in the patient would be a Doppler, a color Doppler, so that I can identify the thrombus. This image that is shown before you is characteristically showing a thrombus in one of the hepatic veins of the patient. Though the image it shows the branching pattern of the hepatic vein, it highlights the fact that there is a occlusion, a definitive mass which is seen in the middle of the hepatic vein. You can see the caliber of the hepatic vein, and then you can notice the fact there's a thrombus growing in the hepatic vein of the patient. So let's quickly just work up on the next slide. What is the workup of patients who are suffering from Budd-Chiari syndrome? Ultrasound, why am I doing it? One, simply because of the fact that I want to rule out conditions causing right upper quadrant pain like gallstones. I want to rule out cholecystitis. I want to rule out cholelithiasis in a patient. One finding in the ultrasound that would tell you that this could be Budd-Chiari syndrome is the caudate lobe enlargement. You will switch on the color Doppler and you would be able to identify the cause here. You can see in the image which I am showing here before you the presence of dilated superficial veins on the abdominal wall of the patient. There is also a very significant distension of the abdomen, the tense abdominal wall. Ascites can definitely be seen in these patients. So it's a good idea that after doing a Doppler, I do a ascitic tap in this condition. Once I do a ascitic tap, in the initial part of the illness, the serum albumin ascites gradient, that is SAG, in this condition,
it will be more than 1.1.
This is because of increased pressure. This is the transliterative variety, so the proteins will be relatively lesser in the initial part, and therefore the SAG values will be more than 1.1. If you do a LFT in this patient, serum bilirubin may or may not be elevated, but liver enzymes will definitely be deranged. It's not a very striking elevation of enzymes initially, but yes, bilirubin values can definitely be elevated in the acute presentation. Even MRI has been done for workup of these patients. Considering the MRI facility for abdomen being not routinely available, if he says in a question, what is the best test to confirm the diagnosis of Budd-Chiari syndrome, then the best test to confirm the diagnosis would be answered as hepatic venography. With interventional studies being available at most hospitals now in India gradually, with government pumping up more money, increasing the amount of health expenditure in GDP, of percentage of GDP being invested into health, we do have now invasive, I would say, interventional studies available, and hepatic venography is the best way to identify this condition. Otherwise, I said, like, if you have less resources, ultrasound Doppler would do the trick for you. For the treatment of this condition, anticoagulation is the one that is standardly used in government hospitals. This image shows nutmeg liver. I have shown this nutmeg liver to highlight the fact that if you fail to diagnose this condition, then the liver will obviously get destroyed, and if the guy is lucky, he'll end up with a cirrhosis and he'll end up with a development of a nutmeg liver, and I don't want that to happen. So now let us study what is the treatment that is best suited for these patients. Like I said, in a government hospital, you will obviously go in for anticoagulation. You will be using heparin. You might even use thrombolytic drugs in the patient. But then what they have recommended is the EACL, the ESL, the European Association. They are basically the EASL guidelines. They basically recommend a balloon angioplasty for management of this particular case, so that we can destroy the thrombus in situ and the restoration of blood supply can be there. So when you have to choose between anticoagulation and balloon angioplasty, answer balloon angioplasty, since it is the EASL guidelines. However, in a question, if he mentions regarding the chronic form of Budd-Chiari syndrome, and he says, what would you like to do for these patients because they're having portal hypertension, I would like to go in for TIPS, that is transjugular intrahepatic portosystemic shunting. Since the patients will be having ascites, I'll anyway have to give spironolactone. That is the standard treatment that you'll be giving for any patient who's having ascites, who's having portal hypertension, is having a decompensated cirrhosis. Ideally, for patients who are going towards irreversible damage to the liver and they're having end-stage liver disease, it is liver transplantation which is to be done in the patient. Failing a liver transplantation, obviously you can understand the mortality rates will be higher. Overall, if the question gives you a acute presentation of Budd chiary, and he says that what is the best treatment in an acute presentation, and he says anticoagulation also and balloon angioplasty also, the answer is balloon angioplasty. If he says the chronic presentation where he is mentioning a decompensated liver, he is mentioning what a nutmeg liver developing in a patient. Nutmeg, the red color is all because of congestion, the venous congestion that is developing in this case. So if he specifies the fact that there is a nutmeg liver present in a patient and he says what would you do in the patient, then obviously it is liver transplantation which is recommended for management of this condition. So I have described one of I would say a rare disorder related to the liver, and it can very easily be misdiagnosed as a cholecystitis cholelithiasis in a patient. And remember, the leading cause for this is hematological causes, that is polycythemia vera and PNH, the workup for which will obviously be done subsequently. Thank you so much for listening.